Hello and welcome to the 2021 Virtual Health Summit convening in Part 3 of Health Integration, Innovation, and Racial Justice. Our focus is on defining action to achieve health equity through oral systemic integration. We'd like to give special thanks to our planning committee members, and we'd also like to recognize our sponsors. We begin with our HBCU partners, Tennessee State University, Fisk University, and American Baptist College. We would also like to give special thanks to our corporate sponsors, Delta Dental, Henry Schein, DentaQuest, CareQuest Institute for Oral Health, and Bridges for the Deaf and Hard of Hearing. Please stand by for opening remarks from Dr. Sheree Farmer-Dixon, Dean of the Dental School at Meharry Medical College.
Good evening, and welcome to the third session in our Call to Action series on health equity. Throughout our program, we have emphasized the need to create a health system that is accessible, affordable, and of high quality for everyone, and a system that does not separate the mouth from the rest of the body. We have acknowledged that no single institution, organization, profession, or individual can accomplish the future of health equity by itself. This evening's session is about how we can work together toward that future. In other words, how we will move from a call to action to a collective action. That is why I am grateful for your participation this evening. This is an opportunity time. This is an important time in our history to bring everyone together, moving in the same direction toward a promising future. We are fortunate to have an accomplished group of panelists this evening that span decades of leadership in civic engagement, the health professions, academia, public and community service, and business. Each of these leaders is committed to bringing about the future of health that is inclusive and just. I want to thank our sponsors, our planning committee, our HBCU partners, and speakers for your support and preparation for tonight's session. For the next few minutes, We recall the insights and wisdom that were shared by participants in our first two sessions. Their words continue to inspire us and move us to action.
The Meharry Health Summit is addressing some of the most pressing issues around health equity and the oral systemic health connection.
Knowledge of health inequities is one thing. Mobilizing our resources to eliminate them is another.
The issue of health disparities just keeps coming up. The susceptibility to infection and the availability of care, access to care, is so dramatically different. Then I just think we need to fix those disparities. The trouble is, as you well know better than I, you don't do that overnight. You have to have a decades-long commitment to do it.
We will need to accelerate the movement of health integration for the whole person as well. And so the integration of oral care into healthcare is also an important component in equity.
For many years, dentists have been thought of as separate from medical doctors. Yet, for more than a decade, there have been increasing calls for a paradigm shift that focuses on integration of oral health in improving overall health outcomes. COVID-19 and the health disparities laid bare by the pandemic have heightened the urgency of those calls.
For those of us who have been working to eliminate these disparities, there is no more time to waste. The events of 2020 remind us that if we are silent and do nothing, if we do not come together, unite our efforts for health and well-being, we place our nation at risk of further human and economic burdens.
COVID has unfrozen an awful lot of stuff. Folks are learning to do things differently. The bureaucracy has melted away for a little while we innovation and flexibility, creativity, interprofessional approaches have risen to the fore.
While some say it's the system that's broken, others believe fixing the problem is going to require a different approach.
I think that state governments, the federal government, but also philanthropists should really put money into, if you're really invested in this, if this is something that you think will, change the course of our nation and the health of our families and friends, that people need to put their money where their mouth is and actually invest in health equity programs.
It doesn't always take money. It takes initiative, and it takes people, ground level communication, and using the resources, first of all, that you have to build on what you don't have.
I think there are things that we will have to change on the systemic level around reimbursement and how things are financed to influence how people make decisions. And so sometimes we don't like to think about that because that's not the warm, fuzzy part of being a physician and a dentist. But at the end of the day, a lot of times economic change will influence people to do the right thing.
In a crisis such as a global pandemic, many found that it was health integration that worked.
Other dental leaders, we were able to be the leaders in how we would mobilize other healthcare professionals and move forward in how we help our communities.
The Meharry Health Summit has also highlighted that health equity is not just a professional and clinical conversation.
We've got to look at non-traditional partnerships that involve other kinds of funders and different types of expertise where we can bring in technology and equipment. That is the only way to make something like that happen across the country. Because
we are the leaders that we're looking for. So it's time for us to step up, know what needs to be done. Communities know what they need, work with them, ask them, and we can make things change for the better.
Healthcare leaders hope the call to action will be heard clearly and lead to a national plan for oral systemic health and equity.
Our objectives for the series are clear. We intend to bring people together to elevate racial justice and equity and COVID-19 health disparities, conversations towards mobilizing action and policy change. to incorporate economic, scientific, social, cultural, and professional concepts for treating the whole person and inclusive communities as a pathway to health equity.
Hello, my name is Dr. Maisha Minter-Jordan, and I am the President and CEO of the CareQuest Institute for Oral Health. I'm an internist by training and the former president and CEO of a community health center in Boston, Massachusetts. I say that because I have had, like many of you, a long-standing commitment to ensuring that underserved communities have access to comprehensive and holistic health. But I also know that there's an urgency right now that demands that we as leaders come together to tackle the issue of systemic racism and the resulting health inequities like we have never done before. We know that this problem that has long plagued our country has so many different facets to it, but that also presents opportunities because each of us as leaders brings a different perspective as to how we can finally move the needle and sustain that movement away from the health inequities that have plagued far too many communities across our country. So I know that we together can solve this complex issue, can make the policy change that is needed, to create the data that we can then use to allocate resources that will finally close the gaps of health inequities for too many populations. I am encouraged and inspired by the leadership that will be part of the summit. And I look forward to the determination, resiliency, and strategic planning that will come out of the summit, because each of you will make that happen. Thank you so much.
Good evening, and thank you, Dr. Farmer-Dixon, for that wonderful welcome. I'm Ralph Uccillo. I'm a consultant with Cambridge Concord Associates and Vice President of the Santa Fe Group. I have the privilege tonight of serving as moderator for a very distinguished panel of discussants, and we're going to jump into that in a moment, but I want to tell you a little bit about each of them. Dr. Caswell Evans was the Associate Dean for Prevention and Public Health Services at the University of Illinois, Chicago Dentistry. He was also a faculty member at UIC School of Public Health. And many of us know Dr. Evans as he served as executive editor and project director for Oral Health in America, a report of the US Surgeon General. For 12 years, Dr. Evans was the director of public health programs and services for Los Angeles County Department of Health. He's a member of the National Academy of Medicine, National Academy of Sciences, and past president of the American Public Health Association, also the American Association of Public Health Dentistry, and the American Board of Dental Public Health. I knew Dr. Evans well as he served as the chairman of the DentaQuest Foundation Board of Directors. He also served on the Chicago Board of Health and the boards of the Institute of Medicine of Chicago, Oral Health America, and the Children's Dental Health Project. Welcome, Dr. Evans.
Thank you.
Senator William Frist, many of you are familiar with the senator's work in healthcare. The senator is a son of a physician and an educator, and he's from Tennessee, as you all know. His undergraduate degree is from Princeton University, and then he graduated from Harvard Medical School with honors. And after working 16 years as a surgeon specializing in heart and lung transplant, Senator Frist was elected to the United States Senate, and that was in 1994. Became the first practicing physician to serve in that body since 1928. While in the Senate, he continued annual medical missions to impoverished countries. In 2000, Senator Frist became chairman of the National Republican Senatorial Committee. 2 years later, the Senate Republican Conference elected Dr. Frist to be their party's floor leader. As majority leader, he championed legislation to fight HIV/AIDS globally, to modernize Medicare to include prescription drug coverage for seniors, reduce taxes, achieve K-12 education reform, and Majority Leader Frist retired from the Senate in 2007. Welcome, Senator Frist.
Thank you. Great to be with you.
Good to have you here. And Dr. Lewis Sullivan, welcome. Dr. Sullivan grew up in rural Georgia, and he is graduated from Morehouse College, I give you lots of dates here, Dr. Sullivan, but I won't announce all those. But your bachelor's is in pre-medical programs. You earned your medical degree then from Boston University School of Medicine, entering as the only African American in your class and graduating third in your class back in 1958. You did further training at New York Hospital Cornell Medical Center, and in the mid-70s is when Dr. Sullivan returned to Morehouse, where he helped establish the Morehouse School of Medicine and was appointed founding dean. In 1989, under President George H.W. Bush, Dr. Lewis Sullivan was appointed the U.S. Secretary of Health and Human Services, making him the second African American to serve in that role. After his tenure as Secretary of HHS, Dr. Sullivan returned to Morehouse to serve as a two-time dean and president from 1993 to 2002. Dr. Sullivan is also known to many of us as the co-chair of the President's Commission on HIV and AIDS from 2001 to 2006, and chairman of the President's Commission on Historically Black Colleges and Universities from 2002 to 2009. He is currently chairman and founder of the Sullivan Alliance to Transform the Health Professions and president emeritus of Morehouse School of Medicine. He is also an author, and I'll mention one of his books because it's his memoir, Breaking Ground, My Life in Medicine, published at the University of Georgia in 2015. So welcome to all of you. As I said, it's quite an honor to be working with you this evening. Each of you are among our top healthcare leaders whose voices are influential to how we think about the well-being and safety of people throughout this nation. So I'm going to begin just with a little context setting. As we experience the worst pandemic in over 100 years, the issue of health disparities has become well publicized and no longer a matter for only public health epidemiologists. The disproportion of COVID-19 reminds some of us of similar disparities when we saw things like HIV taking the lives of underrepresented communities. And it's been pretty much the same with infant mortality, substance use disorders, and other chronic conditions. So, as Mahari has initiated this call to action and to change these kinds of outcomes, I wanted to ask each of you, just take a moment, if you could just comment on the particular ways in which the experiences of COVID-19 has influenced your individual thinking about how we should be addressing health inequities now and in the future. And Dr. Evans, could we start with you?
Yes, thank you. Thank you so much, Ralph. And it's great to be on this panel with Dr. Sullivan and Senator Frist. So it's my pleasure to participate. Two comments. First, I want to go back to our word usage and think about the difference between what is a disparity and what is an inequity. The term disparity has served us well, but disparities connotates a numerical difference. It has no particular shading. When we talk about inequities, it brings into focus the issue of social justice. It brings into focus what is equitable. And we have a health system that falls short in the context of inequity. There are clearly differences that we measure in terms of disparities, but when you get down to inequities, we have we do not have a health system that operates to correct those issues.
Thank you.
I think HIV has exacerbated and has really brought into very sharp focus those types of inequities. We'll just start with its disproportionate, substantially disproportionate impact upon elderly, those who are institutionalized, and populations of color and low income. But it also has had a disproportionate effect upon people with health conditions that are underlying that, again, we have not been successful in addressing. Those with chronic conditions, hypertension, diabetes, elevated blood glucose, abnormal lipids. But it's also had behavioral impacts that further exacerbate. With people being at home and under tension, we know that smoking rates and tobacco consumption has increased. Alcohol sales have increased, particularly in terms of bottles of alcohol. There's question as to whether poor nutrition has been affected by people being at home and snacking. Physical activity has been affected. And all of this not only exacerbates what we've been experiencing, but underscores and further brings into focus the issues of health inequities. And these are challenges that that the system has shown it's not prepared for, that we really need to focus on and change if we're going to have a system that in fact produces health as opposed to just treatment of disease.
Yeah. If I might make a quick comment, Dr. Evans, you early on referred to HIV when I'm sure you meant COVID, referring to the conditions that now we're going through. So
if I had mentioned HIV, I misspoke. I thought my comment was in the context of COVID, yes.
Yeah, that's great. Very good. Thank you. And if I might follow Dr. Evans' comments, I would say what this pandemic has shown to me, and I'm sure many others, just how much we have to do as health professionals to really work to improve the health literacy of our population and to increase the trust in our scientific undertakings. Because from my perspective, we have a tremendous dichotomy. We have this scientific breakthrough of developing very effective vaccines in record time. Because I was a medical student back in the 50s when we had polio epidemics, and we had Jonas Salk and Albert Sabin working to develop polio vaccine. It took years. But here we have this new virus that appeared, and within a year, we have developed vaccines that are 94, 95% effective in preventing serious illness or death. So that's a triumph of the advance of our scientific technology. But in marked contrast to that has been the confusion and the distrust of our citizens in the products that we have developed. And I think this says that we have to work to be sure that not only is our science very effective as it is, we also have to increase the level of understanding of our citizens in science, because if it's not used, or if it's mistrusted, and we have divisions in our society as a result of that, it frustrates the best efforts. So I think that the message that I would like to begin with is we have to continue to support good science. We also have to work to improve the public's understanding of science and the trust in science, so they'll be participants and understand it and utilize the benefits of the scientific advances that we have seen here. So that really is a major challenge, because this pandemic has been prolonged, and the number of deaths and illnesses have been greater than they should have been, because we have people who have refused to take the vaccine or have delayed and mistrusted. So we have to work to really make our citizens more comfortable with our science, more understanding, and they utilize these advances that have occurred.
Yeah. Senator Frist, would you like to offer some thoughts about that?
Yeah, first of all, I underscore exactly what Cass and Lou Sullivan have pointed out. And I think the pandemic has shown this bright light on and exacerbated the pre-existing racial and social inequities. And I think the important thing for all of us, and the reason we're paying so much attention to today, is that we can either let this crisis further erode the health access to our most vulnerable and the underserved, or we can use it as a catalyst for change. So the three big takeaways, in addition to what we just heard, that I have from the pandemic is, number one, that big data is important, and not just any big data. Gathered widely and distilled down to the neighborhood level, data can provide a powerful and very detailed roadmap, giving our public health community and the public health experts around the country the data and the information they need to make sure that as we begin reopening of the nation, all of this doesn't fall hardest on America's most vulnerable populations. So the data is important. But beyond that, what we've learned is that we've got to collect this data. We've got to analyze it and report testing data by very specific things. Yes, age and race, but also ethnicity and gender and disability and income. And there are a whole range of social demographic characteristics that we haven't measured and reported in the past. And if we don't do it, we're setting ourselves on a path to recovery or return to some sort of normalcy that will actually exacerbate or make worse the already widespread health and economic disparities, or as Cass so aptly pointed out, inequities that have existed nationwide. So having the detailed, disaggregated data is absolutely necessary to find and understand the existing inequities and then inform the policy and the policymakers and the approaches needed to close those gaps. And we didn't know that at the beginning, or we may have known it, but we didn't apply it. And let me just say, in Nashville, we have a collaborative called Nashville Health, and we put together a health and wellness being survey. And it was the first time in 20 years that locally we've had data like this on our own city. And we found the usual things that you'd expect, but it was defined here locally, regionally, and encourage other people to do the same. Things like African Americans are 5 times more likely here in Nashville to report feeling discrimination with seeking health care in this area compared to white respondents. The LGBT community, the Nashvillians, the LGBT communities here were more likely to be uninsured. They were more likely to report unmet medical care needs because of cost. They were more likely to exhibit elevated levels of things like mental distress compared to the non-LGBT Nashvillians. So data, but it's got to be disaggregated appropriately. The second thing I learned was the importance of bringing care into the home and community setting. And I've seen this again and again, and we all have, but it's been underscored today. And as we've seen it with the pandemic, the difference in impact of having COVID testing sites and vaccination sites in underserved communities, something that Meharry here locally has intimately been involved with in making a reality here in Middle Tennessee, is absolutely critical. We need to be applying the same approach to other things like hypertension screenings and flu vaccinations, cancer screenings, dental cleanings, but this local and community-based approach. And then the last thing I want to elaborate that I learned, though, is the value of virtual health or telehealth or telemedicine. It's not a cure-all, we know, for all the gaps that we have today, but it is hugely powerful and a vital tool. And as we began to reopen, a continued reliance on telemedicine, I believe, can increase access in areas, rural areas and underserved areas, and help, not be the answer, but help combat the social stigma associated with certain types of care like behavioral health and addiction treatment and sexual health. So those are the 3 things that I take away, in addition to what Cass and Lou have pointed out.
Wonderful. And each of you have pointed to the issue of data. And I just want to switch for a moment because, this series is organized by the School of Dentistry. When you look at health disparity data, oral diseases continuously reflect disproportionate outcomes. And Caswell, well, the Surgeon General's report that you co-edited stated these disparities, and we are not seeing much progress as we would hope. So some advocates have even come forward to say oral health is a social justice issue. And I referenced Meharry's publication, the Journal of Healthcare of the Poor and Underserved. Dr. Henry Treadwell and Mary Northbridge in 2007 carried the title, Oral Health is a Measure of a Just Society. Given that dental care is not financed or delivered in the same way as other care is, how can we expect to reduce the inequities without integrating oral health with overall health? Do you want to begin, Caswell, or do you want to give that to someone else?
No, I'm pleased to begin. I think the question stimulates the answer. It can't. Without integration, oral health cannot come close to fulfilling the role that you have just described. I think that there are substantial changes that hopefully some will be spurred by our experience with COVID-19. But I think integration within the larger health system is absolutely necessary. The history of oral health practice and education has been one of separation from general health and welfare, and if you want to call it mainstream medicine. That is beginning to change, but it's beginning to change sporadically. It's not consistent, and we have yet to see the full flower of that of that measure. We lose track of oral health in society and in the health system, not fully recognizing its overall significance. When you think about every aspect of our nutrition through food and liquids comes through the oral cavity. Oral cavity affects our ability to speak, our sense of taste, our impression of ourselves, how we're seen by others. It affects employability. It affects promotability in many instances. Obviously, there is pain and discomfort that can also be reflected. And too often, that is distilled down into a concept of smile. And I think the smile, I think that as an advertisement vehicle serves a purpose, but it also serves it detracts from the true and significance of oral health. Yeah. I think more needs to be done in the educational area, and I think Meharry could be a leader in this regard in terms of integrating, doing a more thorough job of integrating oral health training and education into the medical environment. I think practice needs to change as well, and I think that reimbursement needs to look at the outcomes and the health values of services provided as opposed to just the volume of the services provided. Dentistry provides the services. It's a procedural driven practice, but we need to ask the question, what is the ultimate contribution to oral health and the contribution to health of the procedures? And at the end point, we reimburse and we will reward for the contribution to health and to oral health, as opposed to reward for the contribution of the number of procedures provided. So that's part of the movement of recognizing value as opposed to volume. And that's a step that we have yet to take, but I think it's a very necessary step if we're going to be successful in integrating into the larger health domain. So we have a ways to go.
Okay, thank you. Dr. Sullivan.
Yes, I certainly agree with Dr. Caswell's comments. And what I'd like to add are the following. First of all, dental caries is the most common disease of children. It is much more common in poor children than in children from middle or upper income families. There are a number of reasons for that. First of all, would be good nutrition, a healthy lifestyle. So educating our citizens in terms of what is a healthy lifestyle, what should they do to try and preserve and enhance their health. But it's also a manpower problem. One of the issues we have as a country is access to health professionals. Dentists are located primarily in urban areas. In suburban and rural areas, frequently dental services are not available. So we need to do a better job in seeing that those who are living in those areas that are not well served, that those are improved. We have a shortage of dentists. We also don't have to have a dentist provide every dental service that's available. We have dental hygienists and a new field of dental therapists. And I would relate a story that comes out of Alaska. In Alaska, the Alaska Native Tribal Council noted that they had a severe health problem with oral health among their citizens. There were very few dentists in the state of Alaska. What this group did with the help of a local foundation, was organize a program to send some 24 young high school graduates in Alaska to Australia for 2 years, 24 months to learn the field of dental therapy. Now, dental therapy includes training a health provider to work along with the dentist who has the following skills: the ability to counsel on oral health, to provide fluoride washers, to do dental fillings, and to extract diseased teeth, and to do this in association and under the supervision of a dentist. This, I regret to say, has been resisted by our colleagues in dentistry, though I think they are coming around. But as a physician, I would tell my dental colleagues, in medicine, we went through the same kind of phenomenon. In the 1960s, when Eugene Stead at Duke Medical Center developed a physician's assistant program, physicians in the country resisted this, saw this as competition rather than an opportunity for collaboration, for extending services to a greater degree. Well, that fight in medicine is now over, because anyone going to physicians' offices today will frequently see there is a physician's assistant or nurse practitioner working along with the physician, because physicians have found that these professionals really extend their capability of providing services. So the dental therapy movement is really going around the country. It has been adopted not only in Alaska, but in Oregon, in Minnesota, and is under review for adoption in a number of other states. So having dental therapists will help provide therapy in areas where they're not well served and where the population may not be large enough to support a dentist in that area. So the manpower is another area. But we have to work to improve the health literacy of our citizens, and we also have to see that reimbursement for dental services is available. I know that under consideration in the current Congress is reimbursement for dental services, and this will help. When Medicare was enacted in 1965, this not only provided health care for our population over the age of 65, it also reduced the incidence of poverty in our over 65 population. So I say that we as a nation need to have a healthy population if we are to continue to be a leader internationally. We have to have a very healthy workforce, a well-educated workforce to compete with other nations in this age of technology and information sciences. So this is where having a good dental service is really in the nation's interest, as well as in the interest of those individuals who are not well served by the population. So I'm looking forward to Meharry playing a role in helping to expand the availability of services, of dental services to our populations, and to encourage people to utilize those services so their health will be protected and enhanced.
That's great. Senator Frist, as a cardiologist, you know, I keep hearing people say, oh yeah, take care of your oral health. It has something to do with your heart. Any feedback you want to give to us around the connection there?
Yeah, Ralph, and I really want to bring to a head a little bit about what both Cass and Lou have said. As a heart transplant surgeon, really interesting, I think, from my standpoint, that did look at the outcome of my heart transplant, that looked at the value of my heart transplant, not just the procedure itself, not just the fee-for-service procedure that Cass mentioned talking about, but the outcome. As a heart transplant surgeon, the first thing that I would do is look in the patient's mouth. We do a careful oral exam. And why is that? Because oral health is a window, literally a window into the health of the rest of the body. If you do a thorough examination, and we know this, and the National Academy of Medicine has talked about it, you can detect, and that's why I did it, signs of all sorts of general health problems. It could be a nutritional deficiency, which will impair healing after the transplant. It could be systemic diseases that are recorded in the mouth and can be detected by an exam. It can be an infection, a microbial and a viral or a bacterial infection that after the transplant with immunosuppression would explode. You can see the immune disorders. You can see injuries to the mouth. You can see some cancers in the mouth. It literally is the window to the overall health. But as Cass set out, for too long, and still today, this whole world of dental care and the world of general medical care are largely siloed, separate from each other. And Cass mentioned them. This because you finance them in different ways, two entirely different structures. Education, he mentioned, you're trained in totally different ways. The sites of care are totally different. The workforce that Lou mentioned is different. And that makes it difficult for dentists and physicians to work together to more holistically treat the patient. And then Cass said it, but I'm going to repeat it because it gives me some hope that today, unlike even 5 years ago, reimbursement is beginning to center around what we call value-based care or outcomes or quality, and not just the fee-for-service for the individual procedures that are done, dental procedures or medical procedures themselves. And as reimbursement begins to focus on outcomes and results, this whole determinant of oral health care as being a window to the body means that you need that further integration of the two separately siloed fields coming together. I wrote a little bit about this 2 weeks ago that are in a three-part series in Forbes magazine. And in there, I talked about quality measurements. Now that both oral health care early on, but typical medical systemic care is focusing on quality and quality measures, I believe that gives us an opportunity to more holistically integrate oral health care with general physical health care. And then I would argue also behavioral health and spiritual health and other types of health care. So I'm very excited about the direction, but we have a long way to come to more fully integrate those. But we're on the track to do so.
Yeah, thank you all. That's terrific. On the policy front, it does sound like we're making some progress on a dental benefit and Medicare. I think as Dr. Sullivan referred to, it sounds like the group is in support of taking care of our folks over 65. And you know, one of the things that we've seen, and Dr. Sullivan referenced this, is the role that philanthropy can play. We're just seeing so many dimensions to, you know, making sense of the idea that the mouth is part of the body, and we have to include it in the work of health equity. You know, the next panel following this esteemed panel is going to focus on what kind of action we need to take to make these real changes. Each of you have been out in front of so many health issues. Just in the few minutes we have left, could each of you think about what words of encouragement can you say to, I'll call them the next generation of health activists who are going to put the mouth back in the body, create equity, and have a really affordable and accessible healthcare system that Dr. Farmer-Dixon talked about at the beginning. Any words of encouragement on taking action on health issues?
I'd be happy to jump in. And you mentioned one of them. I think increasingly we are seeing what foundations can do, that they can step in and do all sorts of things. We've seen it with the Robert Wood Johnson Foundation under Rich Besser in the last 3 years, in focusing on the issues that we've talked so much about today. In addition, foundations can step in to finance pilots to show how things like this integration of oral health and primary care can make a difference in outcomes and in quality, and all that will lay the basis for evidence-based issues going forward for future scaling and reimbursement. And I think the big thing that I walk away is kind of what Margaret Mead said as we look for sort of inspirational thoughts. And when Margaret Mead said, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. I think to me that reflects what's going on today by having panels like this, by having the work on the forefront like Meharry and other institutions across the country, and lastly by foundations who can support this evidence-based collection of data and the sorts of quality measures that can be infused in our system. Foundations play that important role.
Thank you so much. Dr. Sullivan.
Yes, I would certainly add to Bill Frist's comments, and I agree fully. I mentioned the field of dental therapy. That effort was started with the Rasmussen Foundation in Alaska They were joined by the Kellogg Foundation and then the Pew Foundation. So all of these really have been educating our public about this new kind of professional who is needed. Another example of foundation leadership is the Josiah Macy Foundation, a relatively small foundation in terms of size grants, but grants of high impact, looking at minority health issues. They have been very important, really pointing out the need for more diversity among the nation's health professionals, whether in dentistry, medicine, physical therapy, or other areas. The thing I would say is this: I am optimistic because we need to have our public, and I see this happening, we need to have our public much more involved in these issues. A good example of such an initiative is the organization Research America, based in Washington, an organization that advocates for support for biomedical research. And that organization, which is about 30 years old, has really worked with the Congress, certainly with Senator Frist when he was there in the Congress, and with other members of Congress from both parties, pointing out the value of supporting biomedical research. And one specific example of that has been what we've talked about earlier, that is the rapid development of a new vaccine against this COVID virus, developed within a year. A remarkable advance. Understanding of the human genome. We now know the blueprint for our genetic analysis, and a lot of therapies are coming from that knowledge. So there are a lot of things that not only can health professionals do, but private citizens can do. Another is really working to improve the level of trust between the health professionals and the communities, because one of the impediments to getting this vaccine that has been developed by our scientific community, one of the impediments has been people not understanding and therefore not trusting this to be a legitimate product when it really is. So we saw in the 20th century improvements, for example, in life expectancy from less than 47 years in the year 1900 to now some 80 years. That happened over the course of the 20th century, with improved health, with better science and continued science, and improved health literacy of our population. 100 years from now, I think we will see that we've made other marvelous advances. It means we have to have the whole community involved in protecting and enhancing our health and understanding the benefits of good health and the benefits of supporting the development of science. And with that kind of involved public, I see great optimism for the future to improve the health of our citizens.
Right. Dr. Evans.
Yeah, thank you. Oh,
each comment just gets better.
I just got a note that my battery's running low. So let me be brief. It's hard to add to what has already been said. I think we need bold leadership. I think we need to have a reimagined and restructured look at how the oral health system is structured. I think we need to be very conscious and very public and very sensitive to the fact that when you look at oral health needs among the public and you think about access to care, the population literally least in need of care comparatively receives the most care. The population literally most in need of care receives the least. That is wrong. It is an inequity straight in our faces, and yet we ignore it as a system. That needs to be looked at directly, and we need to say.
Well, I think we lost Dr. Evans due to power failure there, or at least a battery outage. Gives us a little bit more time, Senator Frist and Dr. Sullivan. And I just wanted to report to you that, as people are writing comments about your statements, there's a lot of appreciation. You really, one person said that all three of you have identified critical issues through a systems lens, which is so powerful. And others really say, these are all workable solutions, but what about the public will? How do we build the public will? We have just a couple of minutes, but each of you have had to convince people that this is the way to go. Is it activism? Is it writing those letters? What kind of, Senator Frist, can we start with you? What did you pay attention to when you were an elected official?
Well, when I was a majority leader, the really thing is to listen. And when you do listen and you do learn, and not just to the lobbyists, and they're important and they have a role, but you know that they have an angle to it. But to listen to the letters that do come in, to the letters to the editor, even in small town newspapers, eventually they filter through. And now with social media, to use social media, right now, for example, the Senate Democrats have a budget resolution that just passed the Senate on party lines, and it included dental benefits. Policymakers are discussing options to make dental care more affordable by broadening dental coverage for people on Medicare. President Biden's budget request includes that as part of the president's healthcare agenda. And it was like improving access to dental, hearing, and vision coverage. But to express openly that support through whatever means of those policies that are on the table today. So it's important for people to know the policies are on the table today, but also then to support them.
Yeah. Dr. Evans, we see you've joined us again. Did you have a couple of final comments before we go to Dr. Sullivan to close out?
Yeah, I'm sorry for the disruption in the transmission. So I was just saying that we have issues of inequity that have to be faced openly and faced boldly. I think that education plays a critical role. The standards by which dental education are regulated and structured dental education need to be looked at in terms of their sufficiency for the future and providing guiding light posts for the future. I think that's how we're going to make that's how we're going to make change. Obviously, the comments made earlier by Dr. Sullivan and Dr. Frist were right on point as far as I'm concerned. I have optimism that we can be more successful in future years and generations in terms of integration of oral health into general health and welfare. It's long overdue, and the time is now.
That's great. Dr. Sullivan, they tell me we have about 30 seconds left, but I want you to have the final word.
Oh, yes. Well, I certainly agree with my two colleagues on the panel, but I would end by saying we need to understand as a nation the benefits that we get from investing in improving our health system. We need to do everything we can to streamline it, but we also need to recognize the benefits to our citizens of improved health. They become more productive citizens and better contributors to our society. That will keep the United States in the leadership role among nations, and we need to have a well-educated, healthy population to have our international leadership. Health is basic to that, and as we apply that, we will be successful as a society.
That's terrific. I want to thank all three of you. I know on behalf of Meharry and certainly my distinct pleasure to speak with you this evening, and I know all of our viewers really appreciate everything that you've shared. I hope that I'll include the three of you in something I'm about to announce. We have an online dialogue platform called Meharry Call to Action. Consider it, and it's showing on the screen for our viewers, and we hope that people will sign on, put some perspectives out there. It gives us a chance to really dialogue with one another, whether we agree or disagree. You can move your dial one way or the other, but you can also put some rationale for why you think that way. This is the kind of dialogue I think we're looking for in terms of bringing consensus forward and in collective action. So I hope we'll see the three of your names there, as well as hundreds of other names on our dialogue platform to keep this conversation going. Thank you so much for your participation tonight. I really appreciate it.
Thank you.
Thank you. I now have the pleasure of introducing our next panel. Our panel of experts that's coming on next is a blend of people from medicine and public health and really community organizing, every aspect of the things that our speakers so far have talked about. This panel is going to be moderated by Sylvia Stevens-Edward, who is the Senior Community Relations Director for Liberty Mutual Insurance and is responsible for managing Liberty's Torchbearers, the worldwide employee community service program for this. Liberty Mutual is a Fortune 500 company. But some of you might know, as I do, of Sylvia's work. It was award-winning. She was the award-winning creator of a program called Jump Up and Go and the 5210 prescription for children's health, which was an obesity program for the Blue Cross and Blue Shield of Massachusetts. She's also an award-winning documentary producer and is the chair of the Museum of African American History and serves as a trustee for the Boston Children's Museum. I have known Sylvia for quite a long time. We worked together in the Albert Schweitzer Fellowship Program, and your commitment, Sylvia, to health equity and to community service and to spreading the word through your media excellence is really, it's a privilege to have you with us tonight. Thank you so much. I'll give you over to you.
Thanks, Ralph. It's a pleasure to be here. As Ralph stated, I was at Blue Cross Blue Shield of Massachusetts for a very long time and then worked with the Albert Schweitzer Fellowship. And in that process, it's really important, and then what I learned from this process is how important oral health really is. And it struck me when Dr. Evans said, it's the entry to your whole body, and people don't think of that. They think about it as the smile, not necessarily as Dr. Frist said, the window into your body. And so I think that that's one of the things that I'm really pleased to still be involved a little bit here, to really bring that to the fore, especially around communicating that with a much broader audience. And so I'm excited to be a part of this panel today. And this particular session is now going to really explore what are the actions that we need to do to make sure that health equity includes an oral health systemic integration. It's very important. We hope the dialogue will initiate a roadmap for actions that will accelerate this change that we're all looking for. Our distinguished panel comes with a long history of and list of accomplishments. However, in the interest of time and to move more swiftly into the discussion, I'm just going to do a brief introduction of each of them. I'm going to begin with Dr. Eleanor Fleming, an associate professor in the Department of Dental Public Health at Meharry Medical College. She is a diplomat for the American Board of Dental Public Health. She earned her dental degree from Meharry Medical College, completed her dental public health residency at Boston University, my alma mater, and earned her PhD from Vanderbilt. Dr. Fleming completed additional postgraduate training as an epidemic intelligence service officer, where she investigated disease outbreaks and conducted stories to promote health equity. She holds a leadership position in the American Association of Public Health Dentistry and the American Public Health Association. She is also actively involved in the National Dental Association, serving as its coronavirus task force. Our next panelist is Ife Teo Johnson, better known as Ife, and is the executive director of the Oral Health Progress and Equity Network, a national nonprofit, nonpartisan organization dedicated to oral health, health equity, and social justice. The organization has a network of over 2,000 members working to advance improvements in oral health, health equity, and social justice for all. Johnson's focus is on improving oral health, which she believes is vital, and we all believe, vital to good overall health. As a change agent, Johnson believes her organization is instrumental in unlocking the doors on the oral health challenges of our nation to ensure that everyone has an equitable chance to thrive. And finally, last but not least, and certainly not as inspiring, is Dr. Remington Richardson, a recent graduate of the School of Dentistry at Meharry Medical College. Dr. Richardson is featured in a 2020 documentary entitled Time, which was a Sundance Film Festival winner and was nominated for a Best Feature Documentary in the 2021 Academy Awards. Dr. Richardson's story is one of resilience that began when his parents went to prison for their role in a bank robbery. As the oldest sibling of 6 children, Dr. Richardson took on the role of watching over his younger brothers. He persevered, beat the odds, and as of the past May, he was the first doctor in his family. He is currently an orthodontics resident at Indiana University. Now, just as level set and add some context for this discussion, we've already established that health equity in this series, that health equity is really important in terms of thinking about oral systemic integration. It's central to health equity. So we're not going to focus on that in this session. With the greater number of people falling through the cracks in the context of the conversation that we're talking about today, it's changed a bit. There's an urgency to it. And in the midst of COVID, the pandemic, and the frailty of our healthcare systems and other social support systems, including our educational systems to understand science, we are in the midst of a social conversation, a political conversation, and cultural dynamics that are rooted in race and social justice. And it makes this conversation complex, complicated, and very difficult at times. These factors have combined to exacerbate the need to act quickly to imagine to create a different future for healthcare. Each of our panelists are involved in efforts to address these issues from the perspective of our healthcare system. Their leadership roles take different forms and activities. The diversity of their expertise will enrich the discussion, inspire imagination, and spur action for what needs to be done now to set up a better total health care for the future. So I'm going to go to my first panelist, and we're going to talk about what the premise of collective action, what will it do, how does it work, and I want to talk about the promises of practices that we're seeing now that really show that this is a possibility. And first I'm going to go to, I think, Dr. Fleming to talk about what your work is involved with at this point in time.
So thank you for that question. And I think to frame where I am in terms of my work, both as a researcher, an epidemiologist, and a professor, it's important that we understand that, as it was so eloquently spoken before, these things, these disparities, these inequities, they don't happen by chance. And a lot of what we need to understand are those systemic root causes. And often those root causes are found in racism. So part of the research that I've been doing is both trying to figure out what an anti-racist practice looks like in dentistry. How does that function in terms of a research agenda, in terms of practice, education, in terms of advocacy? Because it's my belief that if we can disrupt white supremacy as it is embedded into dentistry, the healthcare system, education, transportation, all of these different systems that we know impact health, that's where there are the opportunities to reimagine the delivery care system as has been discussed. Another important piece that I think where my research aligns is looking at pathways to the profession. I think we talk a lot about how the numbers of Black men, Latinx men, American Indian men, like there are a lot of these disparities in terms of workforce that need to be addressed. And there's so many opportunities around pathways that are sustainable. So uncovering where those opportunities are and where the best lessons are for both oral health and medicine, to me, that's where we can start having different conversations about systems, the systems that we actually need to serve the people who unfortunately have not been served.
Ife, I'm going to go to you now. Can you share with us some of the best practices that you've encountered, especially in your work in terms of community organizing in many ways? You're on mute, unfortunately.
Always said I wasn't going to do that. First of all, I wanted to thank you for letting me be part of this wonderful panel. And I want to start off by saying one of the nice things about getting old is that you don't really have to watch your tongue as much. And we're at a point in time where it's important for people to speak frankly about what's going on in our world, for us to be comfortable with being uncomfortable with these kinds of conversations and having really honest conversations about how systemic injustice is affecting our population. At Open, one of the things that we've been working on for the past decade, and even more so recently, is systemic change. How do we really think about oral health as a system? And so we have spent the last year mapping the oral health system. We came up with 5 leverage areas when we looked through it, where we felt that we could have influence in changing the system. And any system, especially one as large as oral health or medical care, is a big, hairy, unwieldy kind of problem. And it's trying to solve it and change it is like playing whack-a-mole. You solve one issue, another one pops up, and another one pops up. The only way we can really make real systemic change is that we have to have networks of people who are willing to come together and face these problems head on all at once. So you mentioned that we had about 2,000 members in our national organization. Actually, now it's about 3,000. And we found 5 leverage points where we feel that we can make real significant change in the oral health system. And we are inviting people to join the network, to work with us on that. We are working with groups from the grassroots level, as we like to say, grassroots, grass middles, and grass tops. The idea of being working on at the community level, the regional level, and the national level, all at the same time. We have to also work at getting a next generation inspired to be advocates for this. And we need to start developing really significant tools that the average person can use to amplify their voice in a way that helps the people on the national level or the top of their local level hear their voice and understand their needs so that we can make those kinds of systemic changes. And I think Dr. Richardson is probably a good example of what can be done when young people are inspired to be bold and take on something that seems overwhelming and undaunting, daunting. And I think this is the time. We are at an unusual time in American history where folks who were surprised that social determinants of health and injustice and discrimination turned out to really be real and that they could see it and they couldn't avoid it. And now folks are, I think, in a bit of a better place to want to do something about changing that. And my hope at this point is that Open can be one of those gateways to make that change.
Great. Dr. Richardson, you are a part of, I think, the solution. So tell us about what you see as really promising practices that are out there.
Everybody is doing well. Honored to be on this panel once again. It is something that is not only important, but it is imperative that these type of conversations continue to happen so that action can then be brought about from them. For me, I'm inspired because I see change that is being made, and the change that is being made, it has to start with, we always talk about the next generation, and it is important as somebody that is of the current and the new generation that I understand that the power lies in the younger generation. When you talk about breaking something systemically, you have to start at the roots and not just hack away at the leaves. And so when you actually start at the roots, you start with the younger generation, the younger kids, and I'm talking elementary, middle school, and high school. And that is so important, is why I do the work that I do here in Indianapolis. And I started a project called the Smile Check Project. And the Smile Check Project, what that does is we go out to community schools and we talk about accountability as well as accessibility. Accountability in the fact that we can be the solution to our problems, that we have those tools, that we have the instruments in order to solve those problems that are plaguing our generation and our communities as a whole, that we as the next generation can be the solution to those problems. And by starting with the younger generation, it makes a large impact. So when we talk about programs that implement change in that way, and programs that reach back to younger generations and give inspiration and show that you can be able to do these type of things, you can be accountable for the problems that you are. Growing up, my grandmother always gave me a quote that has always stuck with me, even to this day. And for anybody that's from the South, you'll definitely get this when it talks about making potato salad. And when you make potato salad, you always start off with the hot, boiling hot water. And that boiling hot water is the same boiling hot water that you put in the eggs. You also put those potatoes in that same boiling hot water. And my grandmother used to always say that same hot boiling water that softened that potato, it hardens the egg. So you're not a product of your environment. Use your environment and your circumstances to make something better out of it. And so by being able to go to these high schools and middle schools and talks to the younger generation about them being accountable, not only for their smile and talking about oral health care awareness, but also talking about the ability to change what exists for you. So as I stand here as a first generation doctor in my family, what a lot of people don't tend to realize is that also means that I'm the first person in my family that has now hit this tax bracket, which is something that completely else you talk about when you talk about disparities and inequalities that exist amongst the different generations and the different races. So when you talk about being able to provide more for yourself, it ultimately allows you to provide more for your family as a whole. And so that is the accountability, and that accessibility allows people to see the work that oral healthcare professions can do, the work that is available, and that the profession of oral healthcare doctors that is out there is available. I didn't see my first Black orthodontist until I was in dental school. And my first Black dentist actually went to church with me. But outside of that, I didn't know that being a Black dentist was even something that was truly possible. And so when you know that something is truly possible, when you know that you don't have any limits, your inspiration is then limitless. You can't really put any sky limit on it because you know that it's so much more that you can do. So I also congratulate Mahari for now implementing a program that does directly a pipeline program. So that pipeline program mentality is also something that we can be able to utilize that increases our diversity within the field of dentistry, because increasing that access also means increasing the access to the profession, not just the healthcare available.
So when I hear you all talk, there are two things that really are popping up to me that are huge, maybe three. One is communications, the fact that we need to communicate more and better with our populations, the minority populations that are actually impacted by health disparities, health inequities. The other one is that inequity, and it also plays a role in terms of wealth inequities. So I want to talk about, in each of your ways, communicating it, making people aware, which is what you just spoke to, Dr. Richardson, is important. But how do you get past the preaching to the choir or just a small population? Because I mean, we're seeing that play out right now with the COVID virus and people with their vaccine hesitancy. So how do you, is that a prototype for thinking about how to communicate oral health in the sense of not knowing how to address it or addressing it better? I'm going to look at you, Ife, because I see you shaking your head.
Well, I'm glad. One of the things that we talk about, and we don't talk about enough, we talk about sustainability, but we don't talk about the sustainability of trust and the importance of trusted messengers in our community. There's a young lady in Detroit named Valisa Perry who works with the Wayne County Oral Health Coalition. When COVID hit in Detroit, she decided that she needed to go do something about this. And she knew that a lot of folks, Detroit got hit disproportionately with COVID. And we had a lot of people who got sick and died. And she wanted to do something about it, to give people a way of getting tested. It started off with getting tested. So she had relationships that she had established with churches. and other faith-based organizations. The faith-based organizations were perfect because they were cohorts that stayed together throughout the year. They knew each other. They had trusted messengers and preachers and deacons and whatnot that could convey information to the congregation. She went and she took trusted doctors out of those congregations to train the pastors about why COVID testing was important and why they should encourage their congregation to get tested and not come back into in-person meetings right away. Because of her doing that, she also got a lab to come in to provide free testing for folks. They were able to get an IRB going where they actually did a study so they could tell folks, how long people who had the antibodies would have the antibodies last. And then when the vaccines came out, because she had already established that trust, she was able to go back into those communities and inspire those folks to get vaccinated. But it's a matter of having that sustainable trust in place and building that network. And you can then people are willing to educate and advocate for the things that you're talking about. At the same time, all people were coming in to get tested. She set up little stations to give information about oral health, demonstrate how to brush your teeth, pass out kits and things of that sort. Those are the kind of things that we need to be doing in our community, looking at the resources that are there and acknowledging the leadership that's already in existence.
Dr. Fleming, as an epidemiologist, how does this model work for you in terms of really getting the science out and having people understand what the needs are?
So basically, actually, I'd like to take a step back and build on what was already shared, because it's important as we think about communication and trusted messengers, like who those people are. And the faith-based community is definitely one where we can look to as a go-to, but one of the emerging best public health practices. And there are scholars at the University of Maryland College Park School of Public Health who've been researching this, and that's engaging barbershops and hairstylists and those trusted community members that aren't the usual suspects, if you will, but where do people go to confide, their deepest, darkest secret? It happens in those places where people feel safe to engage and will listen when there's a barber who's given an edge up, who can explain the COVID vaccine, who can make those connections so that people can get access to the services that they need. Now, as an epidemiologist, I support trusted messengers, clear communication, and the dissemination of information at all levels. So whether that is a dentist, providing some type of counseling around diabetes, or whether it is that barber who's talking about the importance of mental health, or if we think more broadly, just the little pieces of information that we share where we're getting information from trusted sources. And I think one of the things that this pandemic has highlighted is the degree to which those trusted sources aren't always to be trusted, which means that now we need to be clearer in what our messages are and to stick with those messages. Where I used to work, there was a saying called SOTCO. It's your single objective, your single objective communication point, right? And you just repeat it over and over and over and over again. And with our data and with our best practices, some of that is what we need to do, whether it's around the prevention of caries, whether it's around COVID. It's about repeating those messages and making sure that the right people are sharing it at the most appropriate times for people to hear and to act.
I'm going to go to you, Dr. Richardson, with the SMILES program, because I think there's some overlap here in terms of, because you enter talking about SMILES and you talk about health, it's an easier way and less confrontation, or maybe less scary might be the better way to say it. It's less frightening for people to interact with their dentist and talking about oral health, to really then springboard into talking about more of the health impact that your mouth as that orifice that takes everything into your body. It's a powerful kind of space to be in.
Yes, I agree with you. And one thing also that my program director implored upon me, actually to me and all of my co-residents as we were in seminar one day, and it was that as an orthodontist, you are probably the most visited doctor of your patients. What other doctor is your patient going to see monthly like they go and see the orthodontist? So it puts me in a very special predicament, in a very special place, because it gives me direct patient engagement every month that I'm able to touch and talk to that patient. And it gives me the opportunity to implore these type of health information on them once that rapport and that trust has been built. And that is kind of the overlying message above it all. Honestly, it's trust. If you don't trust what's being said or what's being given, the engagement and the compliance is not going to be high at all. So trust plays a very important role. And I mean, that even goes all the way up to leadership when we talk about the COVID crisis that we're in today. The way in which mask mandates and vaccines were handled, had trust been in the right place, we wouldn't be in the predicament that we are in. So trust is something that you have to build. And even, I mean, when you think about trust and you going back to barbershops, as a Black male, I know all about going to the barbershop. And when you go to the barbershop, you go to the barbershop at some of the most important times of your life, whether it's a wedding, whether it is a funeral, whether it is a prom, whether it's a first day of school. So you're going there when you need trust, when you go somewhere that this is a sacred space that I can come to. So any information that I'm able to give in the barbershop, and I've done it before, actually, when I was in Meharry working with the testing sites, and I was able to go into the barbershop and just casually getting a haircut. And the vaccine, when it first came about, was brought up in conversation. And one of the patrons in the barbershop asked, man, what do y'all think about the vaccine? I don't know about it. I don't trust it. But I'm able to be in a space right there to be able to implore that information and build trust with the patient, build trust with, I'm calling them patients, but they're actual just patrons of the barbershop. We're able to build trust with the community because we know that the barbershop is a pillar in the community. Everybody comes to the barbershop, whether it's the principal, whether it's the preacher, whether it's the priest. They all come to the barbershop. So when you have that level of community that's there, that's when you're able to invade and implore trust. So trust is of the utmost importance. And when you build trust, it makes everything else easier because you truly get compliance and you get engagement. And if we are to go anywhere and pour any type of health inequity that we want to eradicate, or we're going to make any mass mandate or put any vaccines in place, you got to have compliance. And you got to have engagement. Those are the two things that go hand in hand, but you don't get them, especially in minority communities where trust has been taken so easily and so for granted. If you don't have trust, you're not going to get what you're looking for, which is the solution to the problem.
Well, one of the things which you also mentioned is the trust means having the workforce, having people who are dentists, who are dental hygienists, who are dental therapists, to be in the neighborhood, to grow that pathway. And this is where we come back to, it's an interesting kind of a circle, trust being someone you know who knows someone you know. And so that's the importance of having healthcare professionals look like the people that they want to serve with the inequities. Let's talk about that a little bit in terms of, I'm going to go to you, Dr. Fleming, because an epidemiologist, it seems like someone that's way out there in the ether land in terms of a regular African-American population.
So I just want to go back to what Dr. Richardson, the point he made from his residency director about the touch point that the orthodontist has with patients. So I did a study with nationally representative data looking at what was the prevalence of people responding that they visited a dental provider who provided them information on tobacco cessation, oral cancer, prediabetes. And time again, those numbers were in the pits, right? I mean, it was ridiculous, the number of people who had risk factors for diseases where there was no screening, no intervention that took place. I bring this up because if we know that people are having encounters with healthcare providers, it begs the question, why aren't they asking the question? Like, why aren't they connecting patients to care? And I don't know. And I raised this question to Dr. Richardson since he posed it, like, what does that mean? Is it a function of time? Is it a function of providers not knowing that that's something within their scope of work? Because to your point, and the question that you actually pose about, having people who look like the patients and providers. So we call that patient-provider concordance. We know that that leads to better health outcomes time and time again. I think the data that's come out from the University of Minnesota looking at maternal mortality and morbidity when there was a Black obstetrician and what happened to Black mothers. So we know that all of these things matter. And again, from the work that I'm doing and studies that I'm trying to explore, it's where are those pathways? And we say pathways because it's not a pipeline. It's not a we put you in and we shoot you out. It is a pathway, meaning it's wandering. There are going to be barriers. There are going to be obstacles. So where can we create those opportunities so that there are more providers, more epidemiologists, more dental therapists, more nurses, more you name it, who look like the patients who need the help. And a lot of that boils down to opportunity. And it's, again, interesting to hear Dr. Richardson make this point about economics, because to a certain extent, this is an economics game. You know, education is expensive. There are not a lot of scholarships. There are not a lot of opportunities. And so the opportunity for funders, for decision makers is to figure out how can we make being a dentist accessible, and not accessible for just those who are willing to take on the burden of debt, but those who are willing to do the work and then return to communities to serve. Because too often that scholarship is a check and a handshake, and not a check and an opportunity to return and practice in those communities where providers are so sorely needed.
One of the things when I was at Blue Cross, we did fund a study that actually with 5210, and because kids went to the dentist twice a year versus going to the doctor once a year. And it was interesting because there was a much clearer conversation about what you put in your mouth, what you put in your body, that they actually, the efficacy of having the dentist speak about 5210 and asking parents about, are there, by 521, it's 5 fruits and vegetables, limiting television time to 2 hours or less, and 1 hour, 0 sugar sweetened vegetables, and 1 hour of physical activity. So those were, it was very interesting to see actually the greater impact that the dentist had than actually the PCP had in terms of actually working with those kids. So the studies are out there that there is definitely a correlation between actually, when you want to take it in the smallest level, putting things in your mouth and understanding what that has to do with the rest of your body. But I'm go ahead.
No, and I was going to say, and conversely, there are studies, I mean, North Carolina's Into the Mouth of Babes is a classic, where you have pediatrician and healthcare providers who are seeing those infants and toddlers for the millions of visits that they go to see a physician or healthcare provider for, providing fluoride varnish, looking into the mouth and making those referrals. So we know the evidence is there. Right? There is an abundance of evidence where interprofessional practice makes a difference. And the question becomes is how do we make those practices both sustainable and, to Dr. Richardson's point, one where people can potentially either be reimbursed or somehow encouraged to do the work. To me, that becomes a systems question.
So when we get to systems, which is again that how much it costs to go to school to become a dentist, an orthodontist, that's a barrier. Okay. And then because when you come out, you have all the loans that go along with that. So that's a barrier to trust in terms of having more people in your community. So when you start to peel that onion, there's lots of things that are going on that impact, I guess, a more holistic view of the body and health and how that integrated system works. Are there any ideas out there about how that can be engaged?
Well, one of the things that definitely comes up is policy. I think it was Hubert Humphrey that said something like, the moral test of a society is how they treat people at the dawn of life, as children, and the twilight of life, and elders, and in the shadows of life for the needy, the sick, and the handicapped, or something like that. And I think we have failed the moral test here. We have not generated enough political will to foster the support of people of color going into some of these areas of medicine, of helping to integrate this. It's as if we have decided that it's not important to the legislation that comes out to integrate health and well-being, and I'm sorry, medical and dental integration, so that we're getting those kinds of activities happening in our community. But if we're going to look at issues of trust and finding trusted messengers to carry this message into the community, we also have to make sure that it's economically viable. And to do that, that requires policy changes to make it so that when someone comes out of medical school or dental school, $1 billion in debt, that there are ways of making enough money in areas that need them for them to stay in those areas, instead of going to a rich suburban community to pay off those loans. Can we make it so that they can go to an inner city, that they can go to a rural area, that they can go to some of these other locations and build their work there? Folks who need Medicaid, the reimbursement rate on that is so low that a lot of folks will not take Medicaid patients, which sets up another series of issues, because they won't be able to pay off their loans. So we need policies in place that say that we will reward the folks for going into these areas to be those trusted messengers, so that they can afford to also eat and have a house and serve the community as well.
I saw you nodding your head, Dr. Richardson.
Yes, I'm in a complete agreement, especially somebody that is still accumulating student loan debt. I see the receipt. I don't even look at the receipt anymore. But I mean, when you have a situation that exists like that, it makes it very difficult to say that you want to go into a medical field, a medical profession, especially when you come out and you say you want to help and give service into an underserved community and go back into an urban area and give work. But the money is not there. The funding is not there. And so it makes it very challenging, because you also have a footnote of a bill to take care of on one end, and you're also wanting to implement and impact change. So it's a delicate balance that does exist. So, I mean, policy change does need to be changed. Policy does need to be changed. When you think about why we even have separate health relation for medical insurance versus dental insurance, when even the way that in which you take medicine, in which you take pills, comes through the mouth. Your digestive system, any way you break down food, comes through the mouth. Why there exists two different systems, that's where the change also needs to be implemented as well, in my opinion.
There's a question here from the audience wanting to know, and I'm not, what is the racial makeup of orthodontic physicians and patients throughout the country? Do you have any idea?
To even go before getting to orthodontist, which is a specialist, you just talk about dentistry. You're talking about less than 10% of all dentists are African American. And then when you talk about accepting into dental school, to even talk about the generation before that, as an African American male, you were less than 2% likely to get accepted into dental school. Those are whopping numbers. And then you talk about a bulk majority of those students that get into dental school or graduate dental school come from one of the two HBCUs, being Meharry Medical College or Howard School of Dentistry. And that's another reason, that's another issue that should not exist. When we have over 60 dental schools that exist in the country, why is the bulk majority of the African American or minority dental students coming from those two schools? We need more implementation in other schools. I'm the first Black orthodontic resident as a male in over 40 years here in my program in Indiana. Certain things have to change. So even though I am the first, I don't intend to be the last. So it gives me the opportunity to make sure that I do reach back and give back and go and give that exposure, because like you were saying, Dr. Fleming, it is opportunity is a problem. And the way you get more opportunity is through more exposure. So exposure breeds opportunity. So to be able to go to different institutions and schools and tell different children about the opportunities that exist and just giving them exposure of showing them my life story gives them the exposure to see that more opportunities do exist.
Exposure does breed opportunity. I don't dispute that. However, those opportunities have to be couched in systems that allow for those opportunities. So you talk about where and the schools that are training most of the Black, Latinx, and American Indian dental students, and it's not equally distributed across all of the dental schools. And one must wonder, why aren't there policies that support that? I mean, one could argue that there's a lot of work that could go on in places like CODA, which kind of sets the standards for how dental schools operate to make sure that there are teeth around their standards around diversity. So it's not just that you say that you have a pathway program that maybe no one participates in. There are a lot of 3-4 programs at HBCUs that have produced 0 dental students. You can say that you've made efforts to attract underrepresented minority students, but where is the policy? Where is both the carrot and the stick to make sure that institutions do the work so that then Dr. Richardson and other great graduates from Meharry and Howard and Texas A&M and all of these schools that are producing the providers, that they actually have something to stand on other than their individual efforts, because individual efforts are great and amazing, but systems that don't work for people and systems that actually cause harm, those systems have to be reimagined.
With that, that's because I don't want to make sure we can get some roadmap things going here. What are some of the things that need to be reimagined, and how can they be reimagined? You spoke to the policy of entering students into dental school, medical school. What would you say needs to be changed specifically?
In my opinion, specifically what needs to be changed is how we approach health. We talk about health as though it is something that is transactional, and I get it, right? It's something that we can commodify, but is that how health should work? And I think that if there's a concrete step that could be taken, we talked about this years ago of putting health into all policies. Like, why can't we act on that? Why can't we make sure that, the corporations that are coming into Nashville, for example, or the changes that are happening in communities, that when those corporations come to town, they also make an investment in health. And whether that health is in a STEM school or whether that investment is in the built environment, there's so many different things that can happen at a local level that can change people's lives, that can make sure that access is available. Looking at transportation, like, why isn't there functioning public transportation that can get you to the dental clinics and places where they don't have buses or whatever the case may be? So I think understanding what people's individual and collective needs are, supporting them and organizing around those needs, and pressing until the powers that be, whoever the powers may be, act on their behalf. I think that's the work has to come from the people. The saying that, politics is when politics become personal. Well, it's time that we make oral health, it's time that we make health the personal issue that people are both voting about, that they're talking about, and that they're doing the work to make sure that, again, we see those changes, and not just us preaching to the choir, but that choir going out and spreading the good news out in the community.
I'm going to come to you now, Ife. In terms of that networking, when we talk about policy and all politics becomes personal, your organization, can you tell me a little bit about how you guys are going about that in terms of making that real?
Yeah, the 5 levers I was telling you about. One is amplifying consumer voices. Another is advancing oral health policy. And we've had really good work in that area. I think there are about 4 or 5 different pieces of legislation that are in front of Congress now that all have oral health included in them in one way or another. Another one is bringing care to where people are, getting folks out of the dental office or out of the hospital and into the community, emphasizing prevention over intervention. We don't have to wait for somebody to get sick to help them learn how to be well. And then the last one is medical and dental integration. A lot of schools now are starting to teach, I've forgotten the term for it, but it's the idea of integrated care, so that a doctor is learning to look in the mouth, a dentist is learning to take blood pressure. And we had an opportunity to do a conference where we had ER doctors who talked about people coming into the emergency room for dental care, because, you know, if you hurt, you go to the ER to get relief from pain. It doesn't matter whether it's your foot or your mouth, it's probably the same amount of pain either way. And so that's where folks are going. The ER doctors said they have no idea what to do with a dental issue. So they give them some painkillers, a lot of times opioids, send them home. Folks are back, you know, in a few days with maybe an infection that's spreading or whatever, and they don't know where else to go. So we need to start training doctors and dentists on how to work together more effectively. But those are 5 areas. Each of those 5 areas have 4 strategic interventions, and each intervention actually has action steps. We've got about 120 action steps for each of the lever areas. If there's something that you want to do and you want to make a difference, you can find one of those steps where you can move in and start doing work. And I invite anybody who's interested to go to our website, openoralhealth.org, look up the information about that. We give toolkits up there for how to reach your Congress people. We'll give you templates to use for the letters that you need to write, or social media tweets, or whatever you want to send. We will provide you support for the work that you're doing in your area. And this is how we're trying to make a difference. But, you know, and it's free to join. So join us. We got a conference coming up in October. I'd love to see some of the folks from Meharry attend that conference. If you're interested, let me know, and I will see what we can do to help you get there.
For people who want to know in the audience who's actually viewing this, where are you located? And could you say your website again so that people can get in touch with you?
Our office is officially located in DC and in New Orleans. However, I have 10 staff, and we are located in 7 different states. So we do all of our work virtually. I'm in Detroit, and we meet virtually and nationally. We have state representatives and grassroots representatives in just about all 50 states, and regional leads in each of the 4 quadrants of the country. So we are well represented everywhere. If you want to connect with someone, you can go onto our website, openoralhealth.org. It'll take you to our communications platform, where you can connect with all 3,000 people who are part of the network and ask them questions, get connected, you know, find out what you can do. And again, if you are really interested in attending our conference, we'll be holding our conference in St. Louis in October. We'll have it a hybrid. It'll be both in person and virtually. We will have some scholarships available for folks who actually want to attend. And if you let me know, I'll see if we can get some folks in from Meharry.
Great. Dr. Richardson, I'm going to come to you. I know you have your program that you're offering for youth. I'm also going to ask about is there a thought process of having the same way they have a core of medical doctors that are placed in rural communities and communities that need services? Is that something that you would be looking toward to see that operates for dentists as well?
Say that one more time for me.
You know, the what is it? The core. I'm not getting the name right now, but
Service Corps.
The Service Corps, the Medical Service Corps. Is there an integrated policy with them at this point? I'm just asking because I don't know, and I think people would like to know if that is a possibility.
So yes, so the National Health Service Corps, which is a program run by HRSA, it does have opportunities for physicians, dentists, and I think nurses. And it's something where one applies, and for loan forgiveness, you're able to have that repayment and to serve. And it's a great opportunity. I know that people have done it, and I encourage anyone who's interested to take a look at HRSA.gov and look up National Health Service Corps.
Okay. So with that, I'm going to come back to you to say, what else would you give as opportunities for people to really get involved to make a change, a systemic change?
For me, making the change, and especially in reference to dentistry and oral health and healthcare as a whole, is engagement. Engagement is of the utmost importance, and engagement on the level of the generation that is typically often talked about, but a lot of times forgotten about, in the power that they do have. And that is that children are powerful. Children have a lot of power. They have the ability to get their parents to buy them whatever it is that they want them to have. Kids have the natural ability. So when you give children the ability and you equip them with the power to be able to say, hey, mom, these are the things that I'm feeling. Case in point, had a patient that came in for me, and she was telling me that she now encourages her mom to brush at night. And she says she will go to her mom's room, and when her mom is even in bed, she'll wake her up and say, Mom, did you brush before you went to sleep? It's little things like that. It's flipping the script. It's not the mom coming into the room and saying, hey, did you brush? Or before you leave out of the house, did you brush before? But putting it back on the kids and allowing the children to be engaged in their own welfare, because they are the future generation. They are going to be parents on their own one day. So if you are able to implement and engage children at a very young age in the importance of overall oral health and health as a mainstream complex, when you look at that, it gives you the artillery to move forward and be able to implement real change in further growing generations that are to come. So I believe that the engagement at a younger level is of the utmost importance. And that is where I focus all of my work at, because I feel like with my look, even the look of me walking into any room and saying that I am a dentist first, and in a couple of years I will be an orthodontist, I look very different than your traditional dentist and your traditional orthodontist. And to a lot of kids, I look cool. It looks cool to say, hey, I get that all the time. You're a dentist? Yes, this is what a dentist look like. I'm not the traditional old white guy that you traditionally see in a movie or you see when you go into your dental office. So when you make it seem cooler, you give children the opportunity to say, well, maybe that is something that I might want to be involved in. Maybe that is something that I do care about, outside of just even showing them the importance of oral health care and the profession of oral health. So the engagement of the younger generation is where I believe the true change lies, as far as us moving forward and giving the solution to the overall problem, which is our healthcare system.
Great. Fantastic. I think this has been a wonderful conversation. It's shed, I hope for our audience, it shed a new light on some action steps that you can take, both very much locally and as a part of a much broader network. With that, I want to turn this over to Dr. James Hilbreth, the president of Meharry Medical College, and Dr. Sheree Farmer-Dixon, dean of the Meharry School of Dentistry.
Thank you.
Thank you, Sylvia. This has been wonderful. Thank you to all our panelists this evening. You have provided us with much thought about what we can do to move toward a nation of health equity. Your experiences enrich us, and your commitment inspires us to join hearts and hands in a movement of unity and hope. Throughout our series, we have been reminded of the value of health to so many aspects of society. It reminds me of the words of our elders who tell us that without your health, you have nothing. As we think about oral systemic integration, we include in the wisdom of the elders the words of former U.S. Surgeon General David Satcher: without oral health, you are not healthy. As I offer these closing remarks for our third session of Health Equity, a call to action, I find myself feeling the urgency to move in alignment with this wisdom. I find it even more compelling when I think about the work that so many of you are doing to put the wisdom into action. It has been over 20 years since the Surgeon General's report of 2000. We created this series because we know there is both enthusiasm to make greater progress on the issues that were raised in that report, but also because we know many of you share the frustrations that we have a long way to go. I bring to your attention that there was several other calls to action that followed the Surgeon General's report. In 2003, a public-private partnership was initiated to do 5 things, from a call to increase the importance of oral health to overall health, to replicating evidence-based oral health programs, to building the science to better understand oral disease and prevention. An informed group of stakeholders proclaimed a pathway for the nation to improve its health outcomes. Tonight, I call special attention to 2 additional actions that were promoted at that time. One was to diversify the oral health workforce, and the other was to promote partnerships and collaborations to improve oral health. That call to action from 2003 seems really like it could have been written today. It is another reason why I hope that you will embrace the opportunities before us, not only to be politely collaborative in our path forward, but also to commit to joining some of the actions you heard about from our panelists. I hope you will join our future activities as we at Meharry and our partners fulfill our commitments to excellent, accessible, affordable, and quality healthcare. Our mission to build a diverse and inclusive health workforce, and most of all, our commitment to a socially just community. The collective actions that we take at this time will ensure that every person has the opportunity to achieve the best level of well-being that they can. As leaders from all parts of the community, this is the time where we have to move beyond words. I hope that this series is just the beginning of a new era of collaborations among those who are willing and able to initiate change to achieve health equity. There are people who are depending on us. There are people who are depending on us. For those among us who have lived experience of being left out of the healthcare system, we know there is no time to waste. For those who work in our healthcare system, we are tired. I know you're tired. Even today, the pandemic continues to test our physical and emotional capacity to sustain life amidst a void of unified commitment to science and common sense. For those who have been allies on the journey toward health equity, we recognize your concern and commitment and embrace your partnership as we work toward that goal. Finally, let us all offer our gratitude for the courage of those on whose shoulders we stand today. We are grateful that several of those leaders have been part of our webinars during this series. For all the others whose wisdom we carry in their absence, we continue this work in your name. Thank you all for joining us tonight. We will see you again soon as we continue this journey.
Thank you, Dr. Farmer Dixon, for your remarks. And Thank you for your leadership for the Meharry Health Equity Series. The content and spirit of the series has broadened the discussion about how we're going to create a different future for ourselves that results in a more equitable healthcare system. I also want to thank our sponsors, the partners, speakers, panelists, as well as all of those who've joined us for these 3 sessions. The participation has been very impressive, giving me hope that a national plan of action is possible. That plan of action to eliminate health disparities could bring people together around some very basic principles. Principles such as fairness, opportunity, trust, respect, concern for the common good, and provide a foundation on which we can create a plan for health equity, a real plan. We know that it will take more than these principles and these ideals in order to be successful. We are witnessing, unfortunately, challenges to science and factual information, and the resistance to effective public health measures represents a major challenge in the fight against COVID-19 and its variants. We're living in a time where unity of purpose seems extraordinarily difficult to attain. We continue to experience structural and interpersonal violence based on a lack of understanding of how similar we are, just how similar we are, even at a cellular level. A plan for health equity could be a roadmap to the kind of healing that we need at this time. Many of you who are listening or who tuned in today are familiar with Dr. Martin Luther King's statement on health disparities. At a conference in Chicago in March of 1965, he stated, and I quote, "Of all the forms of inequality, injustice in health is the most shocking and the most inhumane, because it often results in physical death," end quote. This is a message of moral outrage from over 50 years ago, but it reflects the problems that we're still facing and discussing today. It is true that an ethical approach is a critical driver for our effort, but I suggest that we must come together with new scientific information, advances in medical and dental care, emerging technologies, in order to build a path to equity that aligns with our moral compass. When we add to this sense of justice our common sense, amazing advancements in knowledge of the human person, and our public will to create policies that support people in healthy communities, then our goals will be understandable and achievable. As Meharry, as an institution, we prepare healthcare professionals for the future, and we are focused on excellence in all of these areas. The institution is in its own process of evolution and transformation as we approach our sesquicentennial in 2026, when the institution turns 150 years old. As we evolve our approaches to excellent overall health with oral health, we want to do so in partnership with others who are moving in the same direction. We see opportunities to nurture those partnerships through public engagement like this series, and we seek a deeper collaboration with those who embrace innovation that will ultimately help us accelerate our goals toward practice improvement and accessible care for everyone. If you are participating in this session, we want to hear from you. We want to learn from you. We want to be successful in building a better healthcare system with you. These are not simply our dreams for the future. These are our commitments to those who are connected to Meharry, connected as faculty, alumni, benefactors, students, the patients in our clinics, and the welcoming communities around us. In fact, this is our commitment to society overall. Meharry's transformation is a process of embracing the future while honoring the past, but always keeping our focus on the optimal health for all. We do play a special role in our service to those who have limited access to care. Our Journal of Healthcare for the Poor and Underserved has disseminated research, data, and insights on how to better serve people who are disproportionately burdened with poor health outcomes. It also focuses on how to transform the systems that perpetuate disparities. So as we go forward from this evening's proceedings, we invite you to work with us towards sustainable solutions and hopefully a national plan of action that will one day be celebrated as among the most just and humane plan for health in the United States. Thank you all for joining us this evening. And again, congratulations to the Dean and her team for an outstanding conference. Thank you.
Thank you, President Hildreth and Dean Farmer-Dixon. This has been a truly engaging discussion with wonderful ideas on how we can all get engaged and act on this important topic of health equity in America. I'm Dr. Celeste Stein, the Director of External Affairs and Development here at Meharry Medical College in the School of Dentistry. We would ask that you would pause for just a moment as we prepare to hear brief remarks from Tennessee State Representative Harold Love and Senator Bill Frist, who join us to pay tribute to you for your outstanding leadership and contributions on health equity through the Health Summit and your work on the coronavirus pandemic. We begin with Representative Love, followed by Senator Frist.
Thank you so much, Dr. Hildreth and Dean Farmer-Dixon, for your work today. I did learn a lot as I was tuned in to a few of the last segments on oral health and the importance of having our younger generation engaged in the process of even keeping the older adults engaged in the process. So thank you for that information about so many needs we have in our community. To that end, let me thank you for your work in COVID-19 testing here in Nashville, Tennessee. I can say without a shadow of a doubt, if it had not been for Meharry Medical College, I know that the African-American community would not have been served as it was served. But more than that, you had persons from other communities come by and get their testing done, which reassured a lot of us that there would be equity, there'd be fairness when it came to making sure that most vulnerable populations weren't going to be left out of making sure that we were not contracting and spreading coronavirus at high levels. I remember so oftentimes driving down Jefferson Street and seeing the beautiful sight of workers out there preparing to receive persons to get the COVID-19 testing, turning right onto DB Todd and seeing the lines of people who are preparing to go in and get tested in their vehicles. So again, once again, thank you for what you've done. You've helped make this fight more winnable. You have helped reassure folks that Meharry indeed is a jewel, not just to Nashville, not just to Tennessee, but to the entire United States of America. So thank you again for your work. And I'll now turn it back over to our moderator.
And I'd like to echo the sentiments regarding the transformative work you're doing on health equity through this summit series and through your exemplary leadership during the pandemic. In fact, I've written a letter to this effect, which we will enter into the congressional record in September when the United States Congress is back in session. Meharry Medical College's efforts to rapidly set up and administer COVID-19 screening sites, to mobilize COVID-19 vaccinations, to equip medical personnel to respond to the pandemic, and to provide sound public health information to Nashvillians and all Tennesseans are making a powerful difference in the lives of our citizens.
We also received a proclamation for you from the Metropolitan Government of Nashville and Davidson County. Unfortunately, Nashville Mayor John Cooper could not be with us, but the proclamation recognizes you for the outstanding work you've done to combat health disparities in America and your tremendous leadership and support in working with the COVID-19 testing sites at a time of heightened risk and exposure to keep us all safe. We turn now for closing reactions and a closing thought from Dr. Farmer-Dixon.
Thank you to everyone, and thank you to all of our panelists and to Dr. Hildreth and his leadership and guidance, and to all of the participants tonight. I hope that you have been inspired. I hope that you have been informed, and I hope that together we will take action. We will answer the call to action and move this agenda forward so that we can have collaborative actions that are in place to achieve health equity for all. This is not the end of our discussion, but there will certainly be a continued effort and continued discussions as we all take action. Stay tuned and look for more information and more opportunities for collaboration from Meharry Medical College. Thank you to all of you all, and have a good evening.